couple things that are important. Again, we talked about this at the end, but let's just make sure it's recorded for posterity's sake, because the final exam schedule, for some reason, are really hard to see on mobile devices. It's just like everything's all jacked up. But here's your final exam date and time. If you're new to SLIC, please note that the times don't exactly overlap with class time. And I can't change them, and you can't do it any other time, okay? So it's Thursday, May 3rd, 9:10 to 11:10. It will be 100 questions on a Scantron. So it'll just be bubble, you'll just fill it in. There's no bonus or anything. So let's talk briefly, off the record, even though it's going to be on here, about under what circumstances you could skip your final. There's only one.
92.
93. 92.5 is what is great. 92.4, I'm going to tell you I'm rounding down because I'm not going to look at your name, right? Because that would be unfair because I really like Natalie. I really want you guys to do well. Some of you guys have never spoken to me, so I'm going to be crap about you. But it doesn't matter at the end, right? Like you get the grade that you earned regardless of whether we're super buds. So I don't negotiate grades at the end because it's completely unethical for me to do that. But if you get a 92.5 or above on what? Let's reiterate to make sure everybody's clear. You have to have had a 92.5 average. Not on everything, right? It's just an average. On all 4 midterms without dropping one and your lab grade. But note to self, I won't have your lab grade by that time, so you have to be confident about your lab grade, which means maybe you need to bake your lab instructor cookies so that he or she will get that lab grade to you soon enough that you know that you can stay home and not take the final, right? So don't bug me about that because that grade doesn't come to me until much later because from them, it has to go from them to the lab coordinator and then to me before it's like officially to me. But you know, like if you know you made a 98% on every damn thing in the lab, then you're probably pretty confident about what you made in the lab. So what I will commit to you is that I will have your 4th test score to you as soon as possible. So you guys are going to take your 4th test on the Thursday before finals, right? But you are actually the last final of the week. So I promise that I will get your 4th test to you, 4th test score to you, no later than Tuesday of finals week, but probably earlier than that. But my priorities are the people who take Monday finals need theirs first, right? And then the people who take Tuesday finals need theirs. And then the people who take Wednesdays. So it's not like you're not the priority, but you guys get a little more leeway. Right? So I'll get them to you as soon as possible. I'll post them for you. They'll be on Canvas and all that kind of stuff. Your lab grade won't be in there, but hopefully you will notice. You will know what it is. Everybody clear? Okay, so let's talk about one last thing. What happens if you just decide that you do not want to show up for the final and you're not making an A? I will not drop that 0. Okay? You do not get to drop a final without taking a final unless you have earned it. And the reason that the A students have earned it is because they can't get any higher. You can't get any A'er than A. But the rest of you, it's actually not punitive. I'm not punishing you. I'm trying to encourage you to continue trying because if you show up and you take your final and it's lower than one of your midterms, I'll drop it for you if you showed up. If it's higher, I'll drop a midterm and keep the final, right? So the final cannot hurt you, but it absolutely can help you, okay? So, and it is comprehensive, okay? So, good? Because sometimes you have a dumb day with one of your midterms. You're like, I don't know what the hell happened that day. Well, this gives you an extra time. So, and my philosophy on it, just so you know, is I want to keep you trying to get the absolute highest score you can until the absolute last date that you can actually do that. Good? Okay, I'm really not trying to screw you over. And then the other thing is that open labs, this Saturday, note to self, is the last Saturday open lab before midterms. Why is that? Because the first midterm starts a week from Friday, and we don't have any open labs after midterms start. Does that make sense? Huh? Oh, sorry. After finals start. Yes, that's what I meant. So everybody understand? So this Saturday, it's not the last open lab, but it's the last Saturday open lab. Okay? And for that reason, on Jordan campus at least, it's going to meet longer hours. I don't know yet whether it's going to meet longer hours on Redwood campus. It might if I can get them to volunteer to do longer open hours, but they haven't told me yet. If it changes, it'll be here. Right? Is that good? Okay. Is there anything else that you guys need to know about what's coming up that I haven't told you? Everybody good? Okay. All right, so we are going to finish lymphatic system and then start urinary system. You guys will start urinary system in lab on Friday as well. Okay, so with lymphatic system, let's see, where were we? I think we were at lymphatic vessels. We were just talking about the fact that the vessels, right, are really thin-walled. They run with the veins, kind of, and they have a whole bunch of valves in them because they're super low pressure. Okay, now what we need to do is we need to talk about the other lymphatic organs. So let's just go through big picture one more time so that we have the forest before we study the trees. So the big picture of all of the lymphatic organs are the vessels, which we just finished talking about. And then the little knots on the vessels. The little knots on the vessels are, of course, called lymph nodes. We're going to learn their structure and function today. But pretty much remember the major function of the lymphatic system is to use the lymphatic system as like sentinels to know when you need to launch an immune response. Does that make sense? So what we are seeing is we're going to see these sentinels sort of sprinkled all around the body, and they're redundant. Your immune system is redundant because you don't just want one opportunity to respond to a pathogen. You want multiple opportunities. So that's what we're going to see today. So we've got our lymph nodes. We'll sort of define those today. Let's see what else we've got. We've got tonsils. Tonsils are masses of those B cells and T cells at the back of, it is recording. Just doesn't show because, wait, is it? No, it's recording. I just had to use a different kind of connector so that it doesn't show up today. Somebody broke the HDMI connector. Tonsils are little chunky masses of those B cells and T cells at the back of your pharynx. And their primary job is that they are going to meet and respond to pathogens that you get exposed to, respiratory pathogens and digestive pathogens, right? So we'll talk about their function in more detail. And then, who can remind me what the spleen has to do with this story? The spleen responds to pathogens and antigens in what fluid? Blood, exactly, yeah? So the lymph nodes respond to antigens and pathogens in lymph, yeah? And the spleen responds to antigens and pathogens in blood. And then the one that everyone gets confused with about, I want to make sure that you understand conceptually before we go into the details. The one that people get confused about is MALT, mucosa-associated lymphatic tissue. What this is stick little clusters of B cells and T cells under your mucous membranes. Remind me, mucous membranes. Moist membranes potentially exposed to the outside. They include the digestive tract, the respiratory tract, and the urogenital tract. Conceptually, is that a great place to put some B cells and T cells just deep to those? Yes? So MALT, they're showing it here associated with the small intestine. It's all over the damn place. It's even in the bronchi of your lungs. It's stuck under like all of the epithelial tissue all over the place, right? So that's mucosa-associated lymphatic tissue, or MALT. And then there's two other little organs that we need to acknowledge when we're talking about this, and that is that the bone marrow has to be part of the lymphatic system because where were the lymphocytes made? Yeah, they were made in the bone marrow, right? And then the other little guy is the thymus, and the thymus we will see today is the site of T cell maturation. It's where we train the generals. Yes, we train them there. That's why they're called T cells. Okay, so now what we're going to do, now that you have the big picture, is start going over the stuff in detail. So before we get into the other structures, let's talk about drainage. Okay, so what we are going to do, big picture, is you are going to suck up fluid that leaked out into your interstitial fluid. You're going to pull it back up into your lymphatic system. And ultimately, it's going to go through those valves, right? And then as it's going through the valves, it will get monitored as it goes through a lymph node, yes? Okay, and as it gets monitored as it goes through a lymph node and makes it up, ultimately what you're going to do is you're going to dump it into the left and right subclavian veins. It's going to make its way back up there. But it has this super weird drainage pattern. I don't know how the hell this evolved, honestly. The weird drainage pattern is this. All of the lymphatic vessels and nodes that drain from just the right side of your head, the right side of your thorax, and your right arm, they all go into one vessel and then into the right subclavian vein. And then the entire rest of your damn body goes up into another vessel and into your left subclavian vein. I have no idea how the hell that happened. But let's find them. You ready? Okay, so you can kind of see it right here. Look, do you see this big honky thing right there? That's gathering everything up from the bottom of your body. This one's going to make it over to the left side. So let's look at it in more detail. Ready? Okay. The entire bottom part of your body and the entire left side are all going to collect. They're going to collect into this big cistern or tank. It's called the cisterna chyli because they actually used to call that fluid chyle. So it's like the chyle tank or the lymphatic fluid tank. Here's what this one's going to do. It's going to run up into this relatively large vessel, do you see, called the thoracic duct, and then that's going to dump into the left subclavian vein, right? That's how all that stuff makes it in there. Good? And notice that you got all those damn vessels that you hate in there as well. All of the azygos, hemiazygos, all this stuff. By the way, I had to dump that question because it was just poorly written, so everybody got it right. Okay, from the test. And then the other side is the right side, just the right side of the head, right arm, and right side of the thorax. Those are all just going to dump into this little teeny vessel right here, ultimately into the to the right subclavian vein. This is called right here the right lymphatic duct, right when it dumps in. Okay, so it's gathering up everything from there. Is that good? Okay, so this drainage pattern is really weird. We don't have it dissected out anywhere because, again, I'm just going to have to decide to do this. I would have to devote an entire thorax, but I just figured out that if I did it, I could actually do all the azygos, hemiazygos. I could also do the sympathetic chain ganglia and these lymphatic structures. So maybe I'll take a thorax and have somebody work on a project to do that. Okay. So now we are going to get into the lymphatic structures. Okay, so, but before we get into the lymphatic structures, what I want you to know is like the building block of almost all of your lymphatic structures is going to be the same thing. And it's called a lymphatic nodule or lymph follicle. So let me just show you a couple of different places, and then we'll draw it on the board so that you can start recognizing it everywhere. So basically, almost all of the tissue that we're going to talk about, whether it's a tonsil or a lymph node or a spleen, is going to be different packages of the same little repeating structure. And this little repeating structure is right here. Do you see it? It's got a pale middle and a dark edge. Do you see that? Yeah? Do you see it here? Pale middle, dark edge? Yeah? Let's show you a couple other places. Do you see it here? Pale middle, dark edge? Okay, what that structure is, it's microscopic, but it's going to be relevant to the stuff that we talked about last time. It is a microscopic structure. It's got a pale middle and a dark edge. The whole thing is called a lymphatic nodule. And here's how it's relevant to the stuff that we talked about last time. What it is packaged B cells and T cells primarily, although there's other stuff in there. So what is in which place? What's actually going to be in the middle is B lymphocytes, right here. Okay, see if you guys can remember. I know I told you I wouldn't test you hard over it, but do you remember what B lymphocytes do in the immune system story that we were talking about last time? Make antibodies, and then they also make memory cells. Yes, good. Got it. Okay, so this is antibodies. Good. Okay. And then around the edges is mostly T lymphocytes. And who remembers what those do in the immune system story? Yeah, they're the command center. They are the generals. They command the B cells. They command other T cells. They command the macrophages. These are the bosses, so I consider them the generals of the entire thing. Got it? Okay, so there's also some macrophages sprinkled in there, but those are just the big brutes, so just keep in mind that those can be damn near anywhere. Okay, so what we are going to have is we're going to have different arrangements of these little nodules. We put them at the back of the throat, big old chunks of them, we call them tonsils. If we put them under a mucous membrane, we call them MALT. If we stick them in the spleen and make them do blood instead of lymph, we call them a spleen. Good? Okay, but it's the same basic Legos that you are using to make different things in different places in the body. So we'll just look for them as we go through. So they are small, but they can group into big chunks. So let's do MALT first, and then we'll do tonsils. Okay, ready? Okay, so MALT is mucosa-associated lymphatic tissue, and you actually labeled it this week or last week in digestive system without knowing what the hell you were labeling, because a little chunk of MALT that is actually under the small intestine is called a Peyer's patch. Didn't you find a Peyer's patch on that model when you labeled it? You should have. So what that is just a specific little nodule, yeah, that's just beneath the mucous membrane, and this is of course simple columnar epithelium, right, made into villi. Sound vaguely familiar? And that's a great place to put some immune cells, because the MALT under the digestive tract will respond to pathogens in the stuff that you absorb. Yes? Digestive pathogens. That's what it's going to respond to. So when it's beneath the small intestine, it's specifically called a Peyer's patch. But you have MALT all over. Just to give you one more example, there's some right underneath the bronchi of the lungs. There's more like behind different portions of the digestive tract. There's some in your urogenital tract. There's some behind the wall of the vagina, some behind the wall of the urethra. They're all over the place because they are supposed to respond to things that get through your mucous membranes. Yes? Okay, so that's the concept of MALT. So before we go on, since MALT is the thing that most people have trouble with, somebody tell me in your words, like I was a really bright 12-year-old that had never heard this material but had completely the capacity to understand it, what MALT is and a little bit of what it does. And remember that 12-year-olds have a very short attention span. Okay, so explain to me in your words, what is MALT and what does it do? You can do it. Kids are way smarter than you imagine. Give it a shot. Because this is what everybody misses about the lymphatic system, because they never actually put it into a nugget that they can remember. I'm going to wait for you. It's going to be uncomfortable for all of us. Be brave. I'll be supportive if you're brave. Go ahead.
Okay. So you know the things that doctors check for, little nodes.
Yeah.
Those are lymph nodes.
Mm-hmm.
And groupings of those that are just under your skin are called MALT.
Good. Just under, almost right, except it's not under the skin, but it's just under
the mucus.
Yeah, but they don't have mucous membranes. Just under like your moist tubes. So this is why people have trouble with MALT, because they can't quite get a little nugget. So I want you to realize that you need to get yourself a nugget so that when I ask you about MALT, you'll be like, oh, I got it. I know what that is, right? Just under a mucous membrane. I got it. Good. Okay. All right. So MALT is found under epithelial tissue, primarily your epithelial tissue that's more likely to get exposed to a pathogen. Okay. And you do actually have a little bit of stuff that might be considered MALT under your skin, but not very much because there's so much other protective mechanism. Okay, now what is a tonsil? To me, a tonsil is just big old chunky MALT. Is all it is, right? So let's find what a tonsil is. So if this is MALT, this is a tonsil. What it is really convoluted big chunks that are at the back of your pharynx of really these nodules that are arranged at the back of your pharynx into big chunks. Why do you need so much back there? Well, because basically I have two body systems that are both exposed to pathogens that are coming together back there. Does that make sense? So you've got your respiratory system and your digestive system pathogens, and that would be first exposure for both of them. So you need not just one guard, you need like an entire phalanx of guards up there, right? Go ahead.
So why do people need to get their tonsils?
So let's talk about that in just a second. So let's first identify and name the tonsils, and then we'll talk about tonsillectomies and stuff. Ready? Okay, so first let's identify the tonsils, and you guys did this in lab this week, or last week, or whenever you did the respiratory one. But although you label them when you're doing respiratory and digestive tract, their primary functionality is immune. It's not respiratory or digestive. Now, can they impede respiratory and digestive function? They can, so let's talk about them. So we have 3 sets of tonsils. The ones that most people just call tonsils are these guys that are right back here at the back of your throat, right? And those are called the palatine tonsils because they're at the back of your palate, right? And the other ones, you don't usually think about these very much, but you have some at the bottom back of your tongue. And those are called the lingual tonsils. These will both respond to digestive pathogens, but also respiratory, because you do breathe with your mouth as well, okay? And then these guys back here at the back of your what pharynx? Which pharynx is this? Yeah, that's the nasopharynx. So those are primarily responding to respiratory pathogens. These are called your pharyngeal tonsils, as in pharynx, but specifically you could say nasopharyngeal tonsils, okay? So these are pharyngeal tonsils. So if you have a person whose anatomy allows especially these palatine tonsils to be really convoluted with lots of dips in them, then sometimes they end up basically providing a hiding place for recurrent repetitive infections. Okay? It usually has to do with the baseline anatomy, and it does tend to be relatively genetically passed on. So the shape of your tonsils can predispose you to having recurrent, so it's basically like you've got your guard house right there at the back, but there's like little hidey holes where, for instance, streptococcus could hide out and then reinfect, and then reinfect, and then reinfect. So when I was a kid, they used to take those damn things out instantaneously. And now we figured out that it would probably be better to leave the guards in if you could. And now what happens is you need a bunch of repetitive, usually strep infections, because it's really, really friendly to strep, before they will consider taking them out. Does anybody know how many they use as the predictor now? Usually if you have X number within a year, 6 or 7 strep infections within a year before they will consider taking out your palatine tonsils. Because, of course, at that point you weigh it out, like how protective are they? They're not particularly protecting anymore. They're actually just reinfecting over and over again, and then they just decide to remove them. So this primarily has to do with just a little anatomical anomaly that you can see running in families. Like, for instance, my son, there's 2 little boys that are 1 year older and 1 year younger than my son right next door, right? Those 2 kids got strep constantly throughout their young childhood, just constantly. And Evan he's never had strep, ever, even though he played with those kids. So what the hell is going on there, right? Am I amazingly more clean than the neighbors? Hell no. Oh my gosh, that guy, I think he might actually be OCD. Like, he cuts the grass around his flower beds with like scissors, like little scissors. It's amazing. I'm like, I don't even know how you manage that. So they are way cleaner than me, but the anatomy of the 2 boys is probably a little different, right? And so it keeps being a house for recurring infections. So quite often they will do a tonsillectomy if it continues to cause more harm than good. Now, the other thing that doesn't happen very frequently, but it does happen, is that people can have the pharyngeal tonsils removed. What's the common name for pharyngeal tonsils? Adenoids, yeah. The adenoid surgery is nowhere near as common as having your palatine tonsils. Under what circumstances do they do adenoid surgery? Any idea? If they're so swollen repetitively that they cause problems with actually breathing through your nose, sometimes if you have them removed, you will stop snoring like a freaking lion. But usually, again, it has to be kind of obstructive, right? Sometimes these can be the cause of obstructive sleep apnea, and you can go remove them and you can get some relief from that. So a lot of times it's just like they're so swollen over and over again that they cause problems with respiration. Is that good? So do you see how these are pretty similar to that? They're just bigger chunks of kind of the same stuff. So that's your tonsils. Okay, and then the other little thing that we don't usually talk about very much with the lymphatic system, but just so you know, originally, evolutionarily, your appendix, your vermiform appendix, which of course you learned when you did the digestive tract this week, its primary function in other animals, other mammals specifically, is that it is a big little loop of MALT that was important for the digestive system, immune system. Ours is so vestigial that we really don't need it and don't use it for that. And sometimes, again, it's more harm than good. If its anatomy is such that it catches stuff as it goes by, then eventually it can become inflamed and irritated to the point that it's better for you to just take it out. And it doesn't seem to impact your immune system at all to remove your appendix. Anybody in here had their appendix removed besides me? No? It used to be far more common than it is now. So yeah, you can remove and it doesn't really do anything to your immune system. Okay, so let's talk about a lymph node. This is where it gets a little confusing, so if you weren't paying attention before, do now. Ready? Okay, so what is a lymph node? First, let's look at the big picture of lymph nodes. So lymph nodes are going to be sprinkled along your lymphatic vessels, right? They're little guard houses along your lymphatic vessels. And their job is to respond to antigens, pathogens, and lymph that you would have picked up from interstitial fluid, right? You suck it out from your interstitial fluid, you end up picking it up, but then you actually march it through a series of lymph nodes. And not just one, right? You could march it through this one, and then, hey, if I didn't get it there, I might get it there, through a whole bunch more on your way up. Again, redundancy in the immune system, not just one opportunity to catch a pathogen. So you've got lymph nodes. Let's just do the principal groups first, and then we'll go back and do the specifics. So you have lymph nodes scattered everywhere, but you have some pretty dependable groups of lymph nodes. You've got these right here that are submandibular, right? You've got these that are cervical. Do any of you guys ever feel it when you're sick and your lymph nodes get bigger? That just has to do with how close they are to the surface, your anatomical variation, and how big they are, right? If it was pinpoint size, you probably wouldn't notice a change in it. And we'll talk about why they get bigger in just a minute. So you've got submandibular, you've got cervical, you've got axillary lymph nodes, yeah? And those are the ones that are usually removed if you have a mastectomy, right? And then you have a bunch in here, and the other big groups that you always have are these inguinal lymph nodes. And these would, of course, increase if you had a cancer in that region, like, for instance, testicular cancer. They're going to take out the inguinal lymph nodes just to make sure. Does that make sense? Okay, so now let's look at an individual lymph node and figure out how they function. But let's imagine that we are looking at a cervical lymph node, right? A lymph node that's going to be draining from the head back into, ultimately, the subclavian veins. Okay, so where are you? Oh, I put it down at the bottom, I forgot. Okay, so your lymph nodes, what they are going to do, big picture before details, they are going to gather fluid, send it through a lymph node. As they send it through, do you recognize your nodules? Do you see them? You recognize those nodules? If not, do you recognize them here? Okay, so those are the lymphatic nodules. You're going to gather fluid in, lymph. You're going to send it by the nodules. You're going to whoop up on whatever needs to whoop up on. You're going to activate T cell and B cell activity. And then you are going to slowly percolate it through the lymph node, right? And then you're going to send it out the other side. So somebody tell me 2 ways that the fluid coming in these afferent lymphatic vessels, yes, afferent lymphatic vessels, is different than the fluid coming out, these efferent lymphatic vessels. There are 2 ways that I can think of that the fluid should be different. It's fine if you only know one. How would the fluid be different? Go ahead.
It removes any sort of foreign or bad.
Yeah, so if something came in this side alive, it would be dead by the time it came out, right? And then what else? What else might be here that wasn't here? Antibodies and memory cells, exactly. And then where's this stuff ultimately going to end up?
In the
Subclavian veins back in the bloodstream. Do you see the big picture before we do the details, right? You bring in something funky, you whoop up on it, you launch an immune system response. Ultimately, that juice is now no longer as likely to be carrying pathogens, but it's more likely to be carrying immune activity. Does that make sense? Okay, so now let's go through the actual details of this stuff. It's not very hard. It looks initially a little hard. Okay, so whenever you have an oval or bean-shaped structure, generally speaking, this little portion where it has a dip and tubes coming out is called the hilus or hilum. You're going to see that on the kidney. You're going to see it on the ovary. You've seen it a bunch of different places. So this is called the hilus or hilum. The outer portion is wrapped in connective tissue. It's just the capsule. You're going to see a capsule and a bunch of stuff. And then if you move into the actual structure, if you have two layers, this is going to be called a cortex and this is going to be called a medulla, right? And then you've got these big open spaces where the fluid would be going by. Those are just called sinuses, okay? So what's going to happen is in the cortex, which is where you're going to have most of your nodules, yeah? As you go by the cortex, you are going to activate T cells, B cells, start your antibody production. And then in the middle, there's more lymphocytes, but there's also a bunch of macrophages. These guys are going to make sure there's nothing alive by the time it leaves, right? So this is the smart part. This is like, hey, if you got past the smart part, I'm going to just whoop up on you because you look funny, right? And then by the time you get to the outside. So cortex, medulla. All of the pathways through are sinuses. Good? Okay. All right, so this is actually what a lymph node looks like. So if you ever see one in a cadaver, you can kind of tell they're like not very pigmented and they've got a bunch of stuff coming into them. And if you touch them, like they feel kind of grainy if you run your fingers through them, like solid but grainy. Okay, so basically how lymph goes is afferent vessels in, then through the cortex, yeah? Then through the medulla, and then out the efferent vessel. Does that make sense? Okay. And then where it's going after that depends on whether there's another lymph node after it or it's ready to dump. So if a lymphocyte, as it was going through, detected a foreign antigen, pathogen, it would motivate the lymphocytes in the lymph node to go through cell division. Because remember, B cells have to make more B cells, right? T cells even make more T cells. You make memory B cells and all that stuff. Going through cell division, if you're exposed to a whole bunch of pathogens, can make the thing big and swollen. Yeah? So if you got a whole bunch of microbes entering a lymph node and it goes through a decent amount of cell division, then the lymph node itself can sometimes become big and swollen. That is called lymphadenopathy, and it's just like, it's not even particularly bad. It means your immune system is working. It's not necessarily comfortable, but it's not particularly bad. And that's a swollen node. Historically, what we called a swollen node was a bubo. And a bubo is where the term bubonic plague came from. So if, for instance, we thought that she was in our village and had bubonic plague and was not yet showing any of the symptoms, we could check for buboes, right? And if she had swollen buboes all over her body, then what did we do? We just kicked her out of the damn village and let her fend for herself. So why the hell don't we see bubonic plague any longer? The pathogen is still around, but it's actually really susceptible to antibiotics. So you don't see it running plague-like through populations. It's not particularly problematic. In addition, we have lots of protections against it. We're a far cleaner society than we used to be. So that is, so what's the difference, by the way? Have you ever gone to the doctor and they feel your lymph nodes and they ask you if they're tender? Yeah, it's actually a good sign if they're tender. Usually cell division because of pathogens causes them to be tender. And if they're not tender, it's slightly more likely to have cancer as a concern because the metastasis of cancer in your buboes is not usually very tender as it goes through. Now, do not go hypochondriac diagnosing yourself with cancer every damn time you get one, right? You have that. Do you have that friend? Do you have a friend who diagnoses him or herself with every damn thing around? I've got a friend who's super duper bright, really well educated about the human body, but also just a complete hypochondriac. And she has gone to the doctor. Every single time she goes, she has 3 possible diagnoses. Always one of them involves a neurological disorder and another one's cancer. And then there's like, oh, and maybe I have strep. Yeah, maybe you have strep. I'm like, why are you doing this to yourself? I mean, but she's not wrong. She's like, I actually read 3 different literatures. I read 3 different journal articles, and I did a Medscape search, and I did all of this stuff, and I'm pretty sure I've got one of these things. And the doctor's like, you don't always have a brain tumor. Okay, go ahead. You have what? 25 lymph nodes? There's so much redundancy in the system that it probably is not. And there was probably a good reason that they removed them, right? Yeah, okay, so then you are probably better off not having those specific regional lymph nodes. And the whole damn thing is just like, okay, we've got foreign invaders. We never know where they're coming from. We're gonna make sure that we are just really well armed in all of these places. But with all of that redundancy to make sure that like nothing goes wrong, you end up having far more than you need. With one exception that we'll talk about in just a second. There is one organ that if you lose it as a child, it depresses your immune system, but it's not usually lymph nodes because you usually have way the hell more than you need in the first place. Okay, so we already talked about the locations. And there's a whole bunch of lymph nodes in a bunch of different places that we didn't talk about, so we only talked about the major groups. Okay, so now let's talk about the spleen. The spleen is very much like a lymph node with the exception of the fact that the spleen monitors what fluid? Blood, exactly. So what the spleen is going to do with blood is the same thing that a lymph node did with lymph. And again, it's redundant, right? So we're trying to make sure that we catch something. And by the way, FYI, if your immune system is working really well, not only are the lymph nodes a common route for metastasis in cancer, they're also one of the only places that you can catch cancer, that you can actually fight it off. Are they perfect? No, they're not. But they are better than not having any of this at all. And your spleen can do it too. Your spleen might catch an abnormally dividing cell and then just whoop up on it. Go ahead.
I heard that like every day your immune system is fighting off cancer cells.
Every single day, yes. And it is really, really good at it because your cells go through abnormal cell division, but you have some cells called, I didn't teach you guys about these, but they're called natural killer cells. They're a type of T cell, and they're specifically looking for cells with your antigen with abnormal morphology, and they're constantly looking for them. They too, however, are commanded by your T lymphocytes. So if your for instance, if your T cell count goes down with somebody with HIV, do you see why you wouldn't be as likely to catch your own cancer cells? Yeah, so we all have precancerous cells that pop up, and we are pretty damn good at catching them. Why? Why do we tend to get cancers as we age? Because our immune system ages as well, yeah? And so you also potentially have been exposed to more carcinogens, and your immune system is not as good at catching them as it used to be. So really it only takes one aggressive one to get through, right? And then cancer can occur. But the stats are with us considering that 7.5 billion people are on the planet. So our immune system is working pretty damn well, especially with cancer protection. I realize that's not comfortable to an individual who has cancer, but it is protecting us. Okay, so here's what you already know about the spleen. You know it gets blood from the splenic artery and it drains with the splenic vein. But what I want you to think about is, again, how is the blood going to be different in the splenic artery and the splenic vein after we go through this story, right? Okay, so with the spleen, mostly what it is in the left hypochondriac region, kind of tucked under your ribs. That'll be important. Except in this new cadaver that we have on Jordan campus, the new one that they're dissecting in the prep room, ask to see her if you have a lab instructor who might be friendly to showing it. She's got some weird crap going on. First off, everything worked fine because she was 95, right? So it wasn't, oh my gosh, yeah, but the weird liver. But then I thought she was missing a spleen, but she wasn't missing a spleen. It's just like, it was in a weird place, and it doesn't even look like a damn spleen. First of all, her liver is this wide. It goes all the way across, and she's got little, like, extra lobes going on. What the hell is going on there? And then when I looked at it, I was like, oh, okay, her liver is so big because she doesn't have a spleen for whatever reason. But it didn't look like way down there and slightly behind, close to her kidney. And then when we found it, the thing is not like one spleen, it's like 4 little individual knobby things that all are supplied. I don't know what the hell's going on. I've never seen anything like it. The weirdest looking thing ever. So you get this little multi-lobed little spleen collection, like a little spleen party back there, and it's not even in the right place. So go look at that. If you like ask your lab instructor to go show you on Saturday or something, it's really cool, and I don't understand it yet. So the next point is going to be I will take pictures of it and send it to the body donor program and say WTF, because they dissect like 30 bodies per year, right? And he's been doing it, Carrie's been doing that for like 35 years. So if like, I hope it's something he's never seen before, because I would feel like I won, but he's probably seen it. Be like, so anyway, she's got a confusing spleen, but mostly the spleen is over here. And it's just one chunk, and nobody ever knew what it did until they got to college. You're like, yeah, I guess you got one. It probably does something. So here's a spleen. And then if you take a chunk of the spleen, can you see this repeating structure that you were used to seeing elsewhere? So the spleen has a bunch of different functions. One of its major functions is related to immune stuff. But it also, for instance, blood cells in case you needed them. And if you hemorrhage, it'll like dump those in. And then, do you remember way back when, at the beginning of the semester, I told you before you had bones, your spleen actually made blood cells for you? It remembers how to do that. So if you're an otherwise healthy person and you hemorrhage, your spleen will go, I got you, bro, and it'll make some blood cells too. And then it stores some extra platelets and stuff like that. All of that stuff primarily goes along like right here, not in these guys, okay? So the spleen has what we call red pulp and white pulp. The white pulp has that white center in it, so you can always tell. So the white pulp is basically kind of the immune stuff, and the red pulp is the other functions of the spleen. Okay, so here's how this works. The other function of the spleen is what you're going to do is you are going to bring blood in from the splenic artery, and you're going to split, 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 right, until you get to one of these. And one of those is going to be a branch ultimately that came from the splenic artery. And then you're going to run that blood by your T cells and B cells. Yeah? And if you encounter a pathogen, hopefully you will whoop up on it, and then you're going to make some what? Memory B cells, antibodies, all of that business, right? And then you're going to send that back into the splenic vein, right? That makes sense? So that's the immune function. It does the same thing that a lymph node does to a different fluid. Yes? And then, of course, remember, where is this blood going to go from the splenic vein? It's going to go into what? Yeah, it's going to go into hepatic portal circulation. Just in case, right, you absorb something that you didn't catch. Do you see the redundancy? So you had the MALT, right? Maybe I caught it there. What if I didn't catch it with the MALT and I send it into the bloodstream? Well, I'm going to send it to the liver, but I'm also going to send in warriors from the spleen to take care of it. It's actually really amazing, right? It's the reason that you survived childhood, right? All of this redundancy is the reason that you survived childhood. Especially, did anybody else have a child? My child was constantly trying to get sick. He must have an amazing immune system. My child used to, I have no idea why, lick doorknobs in public places. Like you couldn't even get to him fast enough. And then one time we were walking through a parking lot and the child sees gum stuck to the sidewalk. Guess what he did? He tried to chew it off the sidewalk. I'm like, oh my God, who is your mother? Looking around. I was like, ah! And then eventually I made him really paranoid about it, and now he's super neurotic about being clean because I think I overcompensated a little. He's like, I have to brush my teeth because the bacteria will poop on my teeth and make holes. And I'm like, so he gets freaked out if he can't brush his teeth, like, ah! Like, all right, one extreme or the other, Melanie, apparently. Okay. So basically we have the white pulp and then we've got the red pulp, and the red pulp is mostly doing other things. And then the splenic cords are, this is all red pulp and splenic cords. The cords are where you store your excess stuff. Okay, so talk a little bit about spleen. So the spleen is really, really important when you are building your developing immune system, because if you lost your spleen during childhood, you would lose the capacity to monitor and respond to pathogens in the blood, Does that make sense? Okay. So removal of a spleen in an adult is not uncommon because the location of the spleen is right here under the ribs. And like if you got into a car accident or something, a lot of times the spleen gets punctured and it's so vascular that it's really hard to stop it from hemorrhaging. So sometimes they just remove it because otherwise you were going to bleed out. In an adult, it doesn't seem to make much difference because you've really already made most of your B cells, antibodies, memory cells. Does that make sense? But if that occurs in a child, you took out the monitoring of an entire set of body fluids that's circulatory. So it depresses the immune system in children. Do they ever recover? Yeah, but a lot of times they have to get everything before they actually recover from it. Does that make sense? Okay, now, the spleen also does erythropoiesis, and we talked about it. And the last thing is also really important in kids, and then we'll move on to the urinary system, and that is the thymus gland. And this is another one that I didn't even learn about until I got to college. The thymus gland is a gland that sits in the mediastinum, kind of on top of the heart, like on top of the great vessels of the heart. And our cadavers are all in their 60s to their 90s, so their thymus is not going to be very big. Your thymus's role is training the generals. And so when do you really need it? You really need it during infancy all the way up to adolescence when you get exposed to most of your pathogens, specifically when you're in school. Like half of the reason you wouldn't want to homeschool your kids is because when they go to college, they're going to get sick every damn day, okay? You got to get those kids some stuff, right? So any other moms that like experience their kids going off to like preschool and then like your entire family is sick for a year because they just like bring home everything and there's like boogers all over the place. So the thymus is proportionally biggest in infancy to the size of the thorax, right? The thymus actually gets bigger and bigger and bigger until adolescence, but your body gets bigger too, so it doesn't look proportionally as big then, right? And then usually by adolescence, you have met many of the pathogens that you need, and then it actually starts to decrease in size. By the time you're in your 60s to your 90s, it just looks like two little strips. Like sometimes you can't even notice that it's actually there. It might just look like fat on the surface of the heart. So the thymus is primarily the site of maturation of your T cells. And have you guys ever heard of SCID, Severe Combined Immunodeficiency Syndrome, which is the bubble boy disease? It's kind of a complex disease, but it involves the thymus not functioning properly. And so let's talk about what would happen if the thymus didn't function properly. So if your thymus couldn't actually do the training of the generals, the maturation of the T cells, right? And specifically they're called helper T cells. If you can't do the maturation of the T cells, remember that if you can't do that, you cannot introduce the pathogen to your B cells and therefore make antibodies and memory cells. Does that make sense? So does their immune system improve over time? It does not improve over time. In addition, it is actually your T cells that cause division in macrophages too. So it's not just their smart immunity that's taken out, it's also their defense that's taken out. So their immune system does not. So a lot of times they have to be completely protected against the outside world for the vast majority of their life. So the hell do you do about this? Well, first of all, it's a really small population. So do we have really good clinical trials? We don't have a lot of clinical trials. We don't have really good data. And it's really hard to figure out how to do a clinical trial of something that might work on someone who already has an immune system that's hardly functional. So for instance, they have considered thymus transplants, but their immune system is already so depressed that you definitely can't give immunosuppressants, right? Like you would normally, right? They've tried embryonic stem cell transplants on animals to see if the thymus would actually continue to grow. So we have not had enough large clinical trials to have really effective treatments for this. So mostly we are just still in the managing the symptoms phase of that. If we could get a really good animal model that we could get skin in, maybe we could actually have some good clinical trials. Okay, so that is lymphatic system. And now we're going to move to urinary system. Urinary system is actually more interesting than you think it is, I promise. So Since we were little kids, we learned this one function of the urinary system that's not particularly interesting, and that is that the urinary system basically is your means of getting rid of waste products, right? But it's really primarily just water-soluble waste products, and the most common water-soluble waste products that you need to get rid of we call nitrogenous waste, and nitrogenous wastes are like urea and uric acid and ammonia. Those are primarily byproducts of the breakdown of proteins in your diet. Proteins in your diet, okay? So this matters, especially right now. Some of you guys are very health conscious and you try to eat relatively high protein, right? What I want you to understand is being health conscious and trying to eat relatively high protein also means that you need to understand that the waste products from that protein have to be cleared through the kidneys. So when you are eating a high protein diet, you should also be doing what? Drinking lots of water. And a lot of people do one but not the other because they don't realize that you have to clear those nitrogenous wastes out of the kidney, and you have to have the water in your system to do it. So if, for instance, you're eating high protein because you're trying to build muscle mass, or you're doing an Atkins diet, or if you're doing a ketogenic diet, right? Any of those things that you are doing, you have to increase the amount of protein. And so you have to increase the amount of water, right? That makes sense? Okay. So the other thing that we hardly ever know until you get to this point is that when you get to phys, you talk even more about this second kidney function than you do about the first. Yes, it does, of course, remove waste products, but your kidney is also your primary determinant of your blood pressure because everything that you pee out came out of your blood plasma. And if you drop your blood volume, what do you do to your blood pressure? You drop your blood pressure, right? And if you retain your blood volume, then you increase your blood pressure. So one of the primary ways that you regulate blood pressure and therefore blood flow is actually at the kidneys. And the kidneys are intimately involved with everything related to cardiovascular function. In addition, the kidneys also get to control how many red blood cells you have, because it is the kidneys that decide whether and when you do erythropoiesis, which is red blood cell production. What happens, let's see if Amber remembers from yesterday, what happens is if your kidneys detect hypoxia, which is low levels of oxygen, they will release a hormone. Do you know what it's called? Yeah, erythropoietin. They will release erythropoietin that tells your bone marrow to make more red blood cells. So again, intimately involved, the urinary system and the cardiovascular system. It's not just about making pee. Okay, and then, so what we are going to do now is just to go over the big picture anatomy. It's super easy. The gross anatomy of the urinary system could not be easier. Okay, so just gross anatomy is relatively easy. So you only got a few parts in the gross anatomy of the urinary system. You got your kidneys, big surprise, right? You got your ureters, you got your urinary bladder, and your urethra. Urethra is different lengths in males and females, of course, and we'll get to that a little bit later, but it's still just a hole or just a passageway from the urinary bladder to the outside of the body. Okay. Now, the only thing that people get confused about with this is that sometimes people confuse urethra and ureter. The way that I remember it is because ureters sounds okay, plural, and urethras does not. I literally have never heard anybody say urethras. Have you? Okay, so you got two ureters, you got one urethra. Got it? Okay, so as far as the gross anatomy, let's start with the kidneys. Kidneys are not hard. And as far as where they are located, they are in the lumbar region of the body, right? Left and right lumbar region. And they are about the size of a bar of soap, a big bar of soap, although they're kind of variable. Like we've got a couple of kidneys that have two renal arteries, one that's almost a horseshoe kidney because of where they develop, but most of them look pretty much like this. They are retroperitoneal, and that's what this is trying to show you. They are behind the peritoneum. So when we open up the cadavers and like move aside all the digestive organs, you don't see the kidneys, and you don't see them because they are packed behind packing tape. They don't flop around with the rest of the organs. So the only reason that you can find them is because we slice through the parietal peritoneum to reveal them for you, right? So they're really smashed up against the back body wall. So they are retroperitoneal, and I'll talk about that again in just a second. Sitting on top of them is the adrenal or suprarenal glands, okay? And those are only peripherally related to kidney function. They make a bunch of hormones. One of them is related to kidney function. So they're just kind of sitting there hanging out. They're just buddies. And as far as structures, not surprisingly, this inner surface with all the tubes coming and going is the hilus or hilum, right? Okay, and it has renal artery, renal vein, ureter coming out. There's some nerves going in and out of there as well. So all that stuff that's kind of familiar to you. All right, so let's start looking at the tissue layers. Okay, so what we are going to see is if we look at the wrappings around the kidney, we can figure out how the kidneys stay where they are, even though they're not suspended from the wall with mesentery. So does it make sense to you guys, because you've seen it this week, that all of your abdominopelvic organs, really, most of them, are suspended some way or another from either each other or from the back body wall by mesentery, right? They're like stuck. But the kidneys aren't. They're just back there. So how the hell do they stay back there? So they're retroperitoneal, so they don't have mesentery associated with them. So what they have is they're stuck back behind the muscles of the back, right? They're between the muscles of the back and the parietal peritoneum. But they have packing material around them, and the packing material around them is what? Fat. So they've got layers of packing material, fat, and then packing tape, sticking them to the back wall. Does that make sense? And like when you're packaging something up to send it off to eBay and it costs you $1 bajillion, you want to make sure you get your money for it, you make sure it's really, really secure in there, right? You're like, here's some packing material, packing tape, stick it to the backside, everything. So this is how the kidneys are. So I want to show you this picture. It's a little confusing to look at, but we can do it together. Okay, so here's where we are, okay? We are looking at the kidney. Okay, so let's just orient ourselves really quickly. So, of course, this is the big hunkin' liver, right? Got it? And Natalie asked me when I came to Open Lab the other day, what are those little, they look like little M&Ms.
It's just like little chocolate chips.
Yeah, it's just little cross sections of these big blood vessels that lead in. Okay, so here is the liver. Now, I want to find the visceral and parietal peritoneum to orient you guys, okay? But it's a little hard to see, so watch. Okay, so on the posterior surface of the liver is going to be the visceral peritoneum on this side. It's not labeled, but it's that first line. And then the one behind it would be the parietal peritoneum. Does that make sense? Okay, so do you see where the parietal peritoneum is? It's that right there, that line right there. Okay, the liver would be coated by visceral. The kidneys are not going to be coated by visceral. Okay, so keep that in mind, and now we are going to find the packing material and how this is arranged from the kidney out, okay? So the kidney has connective tissue around the outside, and the connective tissue around the outside is going to be called the fibrous capsule or the renal capsule. And the fibrous capsule, one of its jobs is to keep pathogens from going from the reproductive tract into the tissues around, from the urinary tract into the tissues around, okay? So here's your your fibrous capsule, and then the first layer of packing materials right here. It's fat that's immediately superficial to the kidney, and that is called the perinephric fat. Perinephric fat, good, okay? And then superficial to that, I have another layer of packing material. Another layer of packing tape, and that is called the renal fascia. So here's what I did. I stuck the kidney against the back body wall, right? I put fat around it. I put tape on top of the fat, right? And that tape is called the renal fascia, but then I wasn't done. I really, really wanted it to be secure. So then I put another layer of packing material called the perinephric fat. Yes, perinephric fat. So peri right here, para right here. Okay, perinephric fat, and then another layer of packing tape, which would be the parietal peritoneum. Does that make sense? So you got kidneys, fat, packing material, which is renal fascia, more fat, packing material, which is parietal peritoneum. Okay, so why does that matter? It matters because they are not actually stuck to anything back there. They're just between the body wall and the parietal peritoneum, and you need to keep that sort of stuff back there. And remember at the beginning of the semester we talked about the fact that if you lose a whole bunch of fat really quickly, like if you get a certain type of cancer that keeps you from being able to eat, or if you get a wasting disease, or if you have anorexia, and what can happen is you lose body fat so quickly that you not only lose subcutaneous fat, but you lose body fat like in your body cavities. And this one, if you lose this fat, they will just slide down between those two layers. So they slide down between the muscle and the parietal peritoneum. And why is that bad? The reason it's bad if they slide down is because the ureter will kink, but the kidney will not stop producing urine. So what it's going to do is end up bathing itself over and over and over again in things that you were trying to get rid of, and it will cause kidney failure. Do you know that one of the reasons that people with anorexia or who are not properly treated die is kidney failure? It's one of the reasons. Go ahead.
So when they drop, what happens to the renal arteries and renal veins? Do they just
renal arteries and yeah, they get stretched as far as they can. And it doesn't usually matter because those are not long enough to keep, but it can actually distort like the position of the aorta and the inferior vena cava. But usually what kills you is that you kink your ureter and it just backs up, basically backs up sewage, right? Into your kidney over and over again. Luckily you have two kidneys and they're kind of redundant. Your kidneys clean your entire blood volume every minute. You can live without one, but you can't live with a dead one, right? Because it's going to eventually start denaturing and the proteins are going to dump into your system. You'll be screwed, okay? So that would be losing crazy amounts of weight, right? Really, really quickly. Okay, so now let's look at the internal gross anatomy of the kidney. So if you do a coronal section of the kidney, one of the things that is really great about the urinary system is that if you get an actual specimen, it looks kind of like the picture, unlike the brain, in which you're like, okay, I guess that might be there. Like, you call it the thalamus, I guess I'll point there the next time, whatever. The kidney looks kind of like this, and this isn't even a fresh one. I'm going to go to the butcher today and see if I can get any fresh pig kidneys. They're going to just think I'm as weird as they usually think I am. Okay, but so notice that you can see some similarities. Here's the capsule that we just talked about, right? But then notice it has an outer portion and an inner portion. The outer portion is the cortex, duh. Inner portion is the medulla, right? This is going to be the hilus, this whole region where like everything comes and goes, a little dip. Do you see that the medulla has all of these pyramids in it, like triangular pyramid things? Yeah? Do you see that you can actually see those here as well? Right? Do you see this big wide open space that leads to the ureter? That's called the renal pelvis, okay? And you can see it here as well. So you can actually see all of the anatomical structures relatively well. Okay, so if you do a coronal section, let's look at the picture first, and then you can, okay. So if you do a coronal section, there's the cortex and there's the medulla. The medulla has the pyramids, and they look like triangles, but realize they're three-dimensional, so they're actually more like pyramids. The base faces the cortex. The point faces the pelvis, okay? And the point actually points into a little cup. So let me tell you why these things are like shaped the way that they are. It looks like you have a bunch of almost parallel lines running toward that point, because you do. Because in each one of those almost parallel lines, you are producing urine, which is going to get dumped into this little cup. Yes? And so they're all going to dump into this little cup. This little pointy part at the end, where the tip of the pyramid dumps into the little cup, is called, you know they had to name it after a nipple, right? So this is your kidney nipple. This is called the renal papilla. That's the point of the pyramid. And then the cup that is going to catch it, now we have urine. We're going to start catching the urine and start making our way out of the body, right? The first cup is called the minor calyx, which means small cup. Right? And then if you gather three minor, or more than one minor calyces, this one actually has 1, 2, 3, and then there's one behind there, 4. Gather up minor calyces into a big cup, That's a major calyx. Gather up all of the major calyces into this that is going to dump into the ureter, and that's called the renal pelvis, right? And then the renal pelvis dumps into the ureter, urinary bladder, urethra, toilet. Got it? Okay. So you can see all of that on a specimen, which is really nice. All right, so let's start with blood flow through the kidney. Go ahead.
So when you get a catheter, you go all the way back?
No.
No, just the bladder.
Just urinary bladder. Yeah. Oh. That would be, I mean, catheters are terrible as it is. But, I mean, you could have something stuck into your ureter, but they don't usually use that. If you, for instance, get kidney stones, they usually just try to blast them with sound and then make you pass them. They don't usually try to go up and get them. If they did, a lot of times the damage causes more problems than anything, like the surgery causes more problems. Catheters are very, very uncomfortable. Your urethra feels very much like a one-way path. And when you get something stuck up there, you're like just a series of no's, just like, no! It's got to be worse for a male because there's a lot more ureter to go up, right? Sorry, urethra to go up. Okay, so I want to start with blood flow to the kidney. You're going to have to do this in lab as well, so you might as well learn it now. You ready? Okay, so with blood flow to the kidney, we know the beginning of the story and that the blood flow to the kidney is going to be really high pressure because it comes directly off of what?
Artery.
Yeah, which big honkin' artery? Abdominal aorta, right? Okay, abdominal aorta gives rise directly to the renal artery. So that alone will make this a higher pressure system than a lot, right? Because as you get further and further away from the aorta, the pressure drops. So this is the renal artery. So for those of you who are flowchart nerds like me, you will like this. For those of you who are not, you don't have to pay attention to the flowchart, but we are going to go through the names of the vessels as we go through this. The objective, guys, is going to be different with the kidneys than it is with most systemic organs. So with all systemic organs, including the kidney, what we have to do is we have to get systemic arterial blood all the way to capillary beds so that we can do gas and nutrient exchange, right? So that we can drop off oxygen, pick up carbon dioxide, all that business, yes? We have to do that with the kidneys, but more. So the kidneys are going to have extra jobs, and the extra jobs are that in addition to going all the way to the capillary beds and doing what you would generally do, when we get to the capillary beds of the kidneys, A, they're going to be rib-lifted, and B, the capillary beds of the kidneys are going to be snuggled up to not another capillary bed, but P-tubes, uriniferous tubules. And the concept is kind of similar to the placenta, in which with the placenta we wanted maternal capillaries and fetal capillaries all snuggled up for exchange but never hooked together, yes? We want, with the kidney, we want kidney capillaries and P-tubes all snuggled up so that I can dump and save and dump and save whatever I select, but I don't want them connected together. Does that make sense? Okay. So the kidney is the site in which you can selectively decide what you are going to keep in the bloodstream and what you are going to dump, right? Okay. So ultimately what we will get is we will get blood tubes next to P-tubes and lots of exchange. But before we get to that microscopic circulation, let's just do the big picture. So the big picture circulation before we get here is going to be this. Note to self, this all the way out here is going to be where you get all of the capillary and urinary exchange. So we're going to have to get out there. But let's do the big picture stuff first. So when we are doing blood flow through the kidney, of course, it all comes abdominal aorta and then renal artery, right? Okay. And then the renal artery are going to give rise to these that run through the pelvis, right? And these are going to be called the segmental arteries, okay? And then the rest of the names kind of make sense if you let them. The segmental arteries will give rise to these guys that run up the sides of the pyramids, and they're called interlobar arteries because somebody said these look like lobes, right? They run up between them. Does that make sense? Interlobar arteries. And then they arch around the base of the pyramid, so we call them arcuate arteries. Got it? And then they give rise to little bicycle spokes from the top of the arcuate arteries. Those are called interlobular arteries, interlobular. So which one sounds bigger, a lobe or a lobule? Lobe, right. So these are interlobar, and these are interlobular. Does that make sense? Okay, now we'll do this part in just a second. Whoops. This is the microscopic circulation where you really get the exchange. But before we do the microscopic circulation, let's just make sure that we can do all the big picture on the way out. So you got all the way up to the interlobular arteries. Magic happens, to be named later. And then we're going to make our way all the way back out. Ready? So what do you think you would call this vein? Interlobular vein leading to this one? Arcuate vein leading to this one? Interlobar. And then some knucklehead decided that these were not segmental veins. I do not know why. So in my head, like, this is a segmental vein, but I don't get to write it down as a segmental vein because they just consider it a continuation of the interlobar veins. And that's just completely arbitrary and dumb to me. I don't like it. So you have complete parallels, arterial flow end and venous flow out, with the exception of the fact that you don't have any segmental veins. So on the way out, we go to renal vein. Now, the blood in the renal vein is going to be different than the blood in the renal artery in a lot of ways. One of the important ways is, of course, it's going to be lower volume, yeah? Because you're always going to lose fluid at the kidneys. That's like literally their job, right? To get rid of stuff into fluid and pee it out. That makes sense? Okay, so let's add in the other part, okay? The other part is called the microcirculation of the kidney, and the microcirculation of the kidney is up here, okay? So what this is showing you is the blood tubes are still blood colored, but the P tubes are yellow. And we're not going to name the P tubes until next time, but we are going to see the blood tubes get right next to them and imagine how the exchange is going to occur. Does that make sense? Okay, so here we went. We got up to the arcuate, which is right here, yeah? And then we got up to what does the arcuate give rise to? Interlobular, yeah? And then the interlobular is going to give rise to what we call the microcirculation of the kidney. And the microcirculation of the kidney, you're going to have to know both for lecture and for lab, so make sure get it as quickly as possible. And you have to know it for phys, too. Okay, so from the interlobular, you are going to give rise to this guy, which will lead to the capillary beds where we can start doing exchange. This is called the afferent arteriole. Afferent arteriole because it's leading to something. You with me? And then this little ball of capillaries is going to be really, really specialized, so it does great filtration. This little ball of capillaries is going to be called the glomerulus. Glomerulus, okay? And then you are going to lead back out of the glomerulus via an efferent arteriole. You with me? And then from there you have two possibilities. This confuses people, so listen. Okay, there are two different types of capillaries that could follow the efferent arteriole. This one's showing you both, which is not how it actually works. We can have either these that wrap around this tube that we call the peritubular capillaries, or we could have these that wrap around this loop that we call the vasa recta, which means straight vessel. Vasa recta means straight vessel. So do you see how here it goes from efferent arteriole either to peritubular capillaries or to vasa recta? Okay, so this one is actually just showing you both. Let me show you what they actually look like, because this one, so this is what it does. You either have peritubular capillaries or collectively you call this the vasa recta. Okay, you don't have both. Okay, so peritubular capillaries or vasa recta. So what is going on here, by the way, is I want you to imagine that you've got, in this situation, you've got blood and you've got urine, right? Imagine that you've got two conveyor belts that are going two different ways. And what you have as you're going by, every single place that there is a conveyor belt, there's the opportunity to take something from one side and put it to the other, right? So by the time you're finished, you are going to have an idealized blood, right? And you are going to have gotten rid of everything unnecessary at the urine. So for instance, you would be getting rid of urea and uric acid, but do you think you'd want to dump any glucose on a good day? No, you want to keep the glucose, right? You want to keep that stuff in there, right? What if I had excess calcium in my system because I drank 3 milkshakes yesterday, right? Oh, I can get rid of a little bit there, right? What if I had not enough water? Oh, I try to retain all of the water possible, Right? Does that make sense? So it's selective that goes on here. So I have either the paratubular capillaries or the vasa recta. And then after I'm done with that, I'm done. And I no longer have blood tubes and P tubes next to one another, because then I dump it back into, what's this vein again? Interlobular vein, and then make my way out, right? And so the blood in the renal vein is going to be different than the blood in the renal artery. So we're going to go through the flow, the whole thing one time. Ready? So I want you to try to do it without looking at the labels if you can. Ready? Okay, so what's this? Renal artery giving rise to segmental artery giving rise to interlobar artery and arcuate artery, and then interlobular. And then the interlobular give rise to the microcirculation. So let's do the microcirculation. From the interlobular, you have this guy, afferent arteriole, leading to this ball, glomerulus, leading to efferent arteriole, and then two possibilities. If it's wrapping around the tube up top, it's called the peritubular capillaries. If it's dipping down to the bottom and more straight, it's called the vasa recta. And then once you're done with the vasa recta, you can make it back into the, what? Interlobular vein, and then back out. Let's go. Interlobular vein down the, interlobular vein down this guy, arcuate, and then interlobar. We know these should be called segmental, but they're not. And then the renal vein. Got it? Okay. So next time what we will do is we will put together the whole blood tube, P tube thing. This guy right here that you are seeing, by the way, is called a nephron. It's the site of exchange between blood and urine. And if you can't remember nephron, you can remember that. Yeah. Okay. And there are 1 million nephrons per kidney, and we will do those on Tuesday.